Well, thank you very much, Professor Rikas, and good afternoon, ladies and gentlemen. So I think the simple answer really to the question which type of radiologist is future-proof is that no radiologist is future-proof. And more than that, I would suggest that no doctor is future-proof. And more than that, I would suggest that no one is future-proof in any walk of life, be that professional or social. Even on a level of, say, the village builder, if another builder comes along who can build better things that people wouldn't want to have more, then the first builder isn't going to have any trade anymore. So none of us is protected by right in terms of being future-proof. So how can we become future-proof? Well, firstly, I would argue that this very much is an active process, something that we have to involve ourselves in order to make ourselves future-proof. And I believe we can only do that by making ourselves indispensable. Indispensable at two levels. Firstly, by adding essential value to patient care, and secondly, by adding essential value to our clinical colleagues. And yes, we have to be better than anyone else at what we do, or else we don't really have any right to be there at all. And I would argue that is true for everyone in life, in whatever walk of life, doctors and radiologists included. I think we ought to ask ourselves, why should it be radiologists who report imaging studies? What can we bring as radiologists to reporting an imaging study that others can't? Well, firstly, it's important to realize and to recognize as radiologists that we are all first trained as doctors. Some of us have had more training in general medicine and surgery than others, but nevertheless, we have all trained as doctors. So it's not really imagers or doctors, it's imagers and doctors being the first thing that we do when we leave university is to train in medicine. And I believe that compared with non-medical people reporting images or undertaking imaging examinations, such as radiographers, for example, or nurses, we as doctors and radiologists can add value by actually understanding the anatomy that we're depicting. We can understand the physiological processes that are going on, and we can understand the disease processes that are affecting that anatomy and that physiology. And we can also add value by applying that understanding to each particular clinical scenario. So it's not a sort of a blanket that will fit all patients. We are considering each individual patient's clinical problem. And we are tailoring our reports, the pertinence, the relevance of our reports to that particular patient with that particular clinical scenario. So when it comes to whether radiologists or other doctors, other clinicians, should report images, well, there's absolutely no reason why any doctor can't report an image if they are sufficiently skilled in it. But I would argue that as radiologists, we have at least had a dedicated training in observational skills and interpretive skills. So that is what we happen to be particularly good at compared with many of our purely clinical colleagues, because they haven't as yet, on the whole, developed these skills to the same extent that we have. But we have to work to maintain that lead. And of course, to maintain that lead, we have to remain at the forefront of knowledge, just as any other clinician would have to remain at the forefront of knowledge to be sought after, to be future-proof, be that a cardiologist or a respiratory physician or a cardiac surgeon or whatever. And we can remain at the forefront of knowledge in three particular areas, in my opinion. Firstly, obviously, in clinical imaging and in interventional radiological expertise, if we're interventional radiologists. But secondly, and it's important to remember that we do have a huge knowledge of this, hardly without trying, really, because we're immersed in it every day, of imaging modalities, the contrast media we use, and the devices that we use in interventional radiology. But we also have a third sphere where we're very knowledgeable because we are at the forefront of the use of digital informatics and software in medicine. So all of us, some to a greater or lesser extent, nevertheless, have a lot of expertise in that area. And I would argue that we need to develop and maintain all those three areas at the forefront of knowledge, because that is one of the reasons why we can become, as radiologists, the best doctors to advise for the present and for the future. It's interesting that in the United Kingdom, what in America would be called a staff radiologist, we are called consultant radiologists. That is our name, if you like, our rank, our job description. And it's more than just a term. To be a consultant radiologist does actually mean that your opinion is being sought. You are being consulted by other doctors as a doctor to add your opinion, based mainly on the imaging, to a particular clinical scenario. So, for example, the intensive care physicians might come down and discuss a case with me, and they would tell me about the case. I've got a difficult case, I don't know what's going on. I know there's a CT's been done. I know it's been reported. Can we go through the images together? I will interact with them as a doctor. What's the lactate? Have you done a bronchoalveolar lavage? And so on. And we will discuss the case with the images as doctor to doctor. And that is adding value to our clinical colleagues and obviously also to the patient. But we, as radiologists, actually have to behave as doctors, not just as imagers who issue a report and then go away and don't have any interaction at all. And many of us, of course, we have so much work to do, and there is such a pressure to get the reports out that any interruption is regarded as annoying. And we want to get away from the interruptions, and we want to shut ourselves away so that we're not interrupted, so we can be as productive as possible. And certainly if we're being paid on a fee per item, then there is an incentive to do that. But I would argue to you that it's only by these clinical interactions and behaving as doctors that we develop a rapport, we build up an interaction with our clinical colleagues, and we contribute and add value. And in these ways, we can maintain best current practice, and we can be involved, and our opinion can be sought after. We can be consulted for planning for the future in all those areas of not just the clinical imaging and its interpretation and its practice, but also the best imaging modalities, their best use, which devices to use, and how we can employ digital informatics across the entire spectrum of clinical care. Maintaining our clinical expertise is, of course, a lifelong personal professional development, as it is in any discipline. It's why all of you have come here today, this week, to ECR. We want to keep abreast of new understanding of disease, and we want to be up to date with new therapeutic developments that change throughout our life, and they change very rapidly. I think it's inevitable that we must develop, all of us, some specialist organ expertise, because we have to remain ahead of the game. We have to be as good, and in fact better, than our clinical colleagues who are specialized in that area. So it's no good me as a chest physician not being able to interpret a high-resolution CT of the chest as well as, and preferably better than, my clinical colleagues. Or if I'm a musculoskeletal radiologist, I have to be able to interpret an ankle MRI better than the orthopedic surgeon who specializes in ankle surgery. So in order to remain in a position where we can add value to our clinical colleagues, we have to maintain our clinical expertise. And there is just so much enormous knowledge out there now that we can't possibly become, best of breed, if you like, in every single area of imaging. So inevitably, there has to be some specialization. But of course, we do, in my opinion, have to maintain certain generalist skills. If we become too specialist, then we also outlive our function. We're not sufficiently flexible. We're not useful enough to be able to report plain images, chest x-rays, skull x-rays and so forth, or do an ultrasound list if we have to. So I think there is a balance here between the two. One absolutely vital area by which we can maintain our clinical expertise is through the MDM, the multidisciplinary team meeting, the MDTM as we call it in the UK. And these, I'm sure many of you have them. I know they've had them on a daily basis in Scandinavia for many years. In the UK, we tend to have them on a weekly basis. These are meetings with clinical colleagues involving oncologists very often, and surgeons and physicians and radiologists and so on, to discuss the clinical cases that are passing through the hospital or that are outpatients, and to decide on a treatment plan and to review them when they come up and they come back and so forth. And I would say to you, if you don't have a multidisciplinary team meeting in your specialist area of expertise, initiate one. Make yourself part of a team. Make yourself indispensable to that area of imaging practice. I believe that we must foster a high profile on the hospital side, because you can't actually be regarded as integral to a clinical team if you're not present, if you're not there. And it must be us to whom the clinicians are turning when they want to know what is the best imaging examination to do next. It's not for them to tell us what they want. It's for us as experts to advise what is best for the patient and most economic, if possible, in that imaging pathway. I would suggest to you also that if you're a multidisciplinary team meeting, it's a good idea, even though it takes time, to prepare complex imaging so that it looks as though you're in control. Well, you've read the literature, you know what's going on, it doesn't take you ages to display the images because you have them all prepared, and with the digital systems you can set up a bookmark or a display profile whereby you can immediately show all the pertinent images. So you're not scrolling through 1,000 images to find the one that you want to show them. Present the imaging yourself at the staff round. Don't let the other clinicians do it. This is your area of expertise, so even if it takes you time, this is what you're good at, this is where you should be. You are there in front of the hospital presenting the imaging to the staff round, or the grand round, as you may call it. Make yourself available for discussion of imaging findings in complex clinical cases. Yes, it's annoying to be interrupted in some ways, but if you're not interrupted, if you're not valued by your colleagues, then you're never going to be part of the team and you're not needed. You have to have a physical presence, and we've found, certainly in the hospitals in which I work, that it's been very useful having a communal digital reporting room, because that becomes a sort of a hub where it attracts clinicians to come and ask about cases that are difficult. Yes, it does interrupt us to some extent, but the payoff is that our opinion is valued, and they seek us out to ask about the imaging when they don't know what to do clinically, and they treat us like doctors when they're actually asking about a case. So I would say that really all those things that I've suggested in terms of fostering a high profile on the hospital site are the exact opposite from teleradiologists. So we, in order to future-proof ourselves in clinical practice as real human beings and part of a clinical team, have to be everything that a teleradiologist isn't. Of course, there are many more detailed practical tips to future-proof ourselves, building on what I've said already. If we actually are performing the ultrasound or performing the interventional imaging, then we are needed, but of course we have to perform it to a high enough standard for that to be of value. We must manage and appropriately use the local imaging services so that we know what's cost-effective, what's efficient, what is the importance of the entire service. You know, we need to be aware of whether there's a good endoscopic ultrasound service, for example. Do we do colour Doppler well in our particular hospital, and so on. And we should ensure, as I've said already, that it's we as radiologists who are deciding on the imaging pathway and protocol that's going to be followed, and making sure that those protocols can answer the actual clinical question that's being asked. So do we, in a chest CT, for example, need inspiratory and expiratory cuts? Do we need the patient to be prone? What phase of contrast do we need what timing to show up a lesion that's likely to be pleural rather than be shown up in the arterial phase, and so on. So we need to be specific and also well informed, and give advice that is tailored to particular clinical situations, depending on what equipment we have available, what the local expertise is, what the local preference might be for certain surgeons, for example. And by justifying that the requests are really useful and standing our ground, because we know what's useful and what isn't for those imaging procedures, we are therefore protecting the patients from unnecessary examinations and very often from unnecessary radiation. And we do need to be available to give advice on problematic cases. And we do need to discuss queries about written reports, because it's only by doing that that we can establish an individual personal rapport and gain respect and friendship very often from our local referring clinicians. We need to be known. We need to tailor the report to the people who are receiving it. So if you're sending a report back to a general practitioner, the kind of language you're using is not necessarily the same as if you're sending it to a highly specialized pulmonary physician, for example. And I think face-to-face training is terribly important, be that with our radiographer colleagues or with junior doctors, with training junior radiologists, training our peers, having peer review meetings and so on, and of course carrying out research within the hospital setting with our clinical colleagues as a team effort. I think it's important to realize that, too, we need to be able to predict the future, not an easy thing to do, in order to become future-proof, but at least we can try. We can ask ourselves, where is healthcare going? What are the changes that we're seeing? And I would suggest that the four main trends are the importance of technology is increasing in all areas, digital society now, the digital medicine, and so on. Costs are always an important issue in whatever country you work in, and there are many new financing systems and ways of calculating health costs and savings. And medicine is becoming much more global, much more international, and we need to be aware of that with markets and services and competition. And of course, patient knowledge and patient demands and patient expectations are increasing all the time. Personalised medicine, access to e-medicine, and so forth. And we need to take all that on board as we move forward. So I think that as radiologists, we need to react to all these things. We need to, but we also need to be proactive in our outlook. We have to adapt to changes, we have to be flexible, but we also have to preserve the quality of what we do, preferably on a global scale. We should learn from the airline industry in improving its safety standards, that they do all these safety checks and so forth on a global scale. They set global standards. And of course, we need to update these changes and these standards as technology and medicine develop. But always, the patient has to remain central in order that we can future-proof ourselves to be useful. So I would say to you that future-proofing isn't a given. It has to be earned, and that's hard work, and it has to be deserved. Otherwise, we don't deserve to exist. Thank you.